talk about why does testosterone go down in men, and then also other areas that we're finding that could potentially be helped with low testosterone. So this graph is not showing it too well, but what this graph is saying is it's declining testosterone with age. Here's your testosterone in your 20s. This number here is 800. By the time you hit, and each of these is a decade. And in your 20s, that's when your testosterone is at a peak. Actually, after you hit 20, it starts going down roughly about a percentage a year. And then by the time you hit your 40s, most guys will have testosterone, median testosterone will be in the 400s, 50s, 60s, 70s, your testosterone is way low. And the real feelings when people start to feel that their testosterone has started going down, it usually takes about the age 35. So I see a lot of athletes starting to retire at that age. Their body starts to wear down, but also their ability to grow muscle mass, things that testosterone is important with, start to decline as well. And by the time you hit 70, unfortunately, your testosterone will be lower than pretty much anyone in their 70s. People who are in their 40s, a third of these men, and I'm right up there, could have low testosterone, and usually that's in association with diabetes or obesity. It makes it more likely that you're going to have low testosterone. But up till recently, it's like, okay, losing your testosterone is just part of aging. You're just getting older. You shouldn't take testosterone because that's what people who try to cheat the system do. The athletes who do steroid abuse. And then this last one, which hopefully we will demystify, is that testosterone causes prostate cancer. I'm going to show you that there's a lot of data showing it doesn't cause it. Now, turning it off could sometimes help, especially for advanced prostate cancer when we give what's called hormonal therapy. But it's mostly not thought to be a cause of prostate cancer anymore. So, just in general, what happens, as we age, everyone, this could be this doesn't look too bad though, but this is what you see in the mirror, but this is what's in the mirror, but this is what you're thinking you see in the mirror. Things like declining vision. Well, if your vision declines, what do? You go get glasses, right? Your hearing starts to diminish. Unless you're like my dad, you go get a hearing aid. Otherwise, a lot of people are in denial. Obstructed blood vessels. You put yourself on aspirin to prevent heart disease. Teeth. Your teeth naturally get bad. What do? We brush with fluoride toothpaste. So we're just trying to set up the idea that you're already doing a lot of things to counter what would otherwise be natural. Testosterone, I'll show you, maybe shouldn't be considered any differently. It is a steroid. It's an anabolic steroid, which means it helps, as opposed to a catabolic. Anabolic steroids help build things. Okay, so it helps increase protein synthesis within cells, i.e., muscles, for example, tissues that are helpful for development and maintenance of your manly characteristics. If you abuse testosterone, if you get high levels of testosterone, you can run into harmful effects. You start to retain fluid, your skin can break out, you can develop acne, your red blood cell count can start to shoot way high into an unsafe territory. If you take oral testosterone, which really isn't available anymore, you could get liver damage. Breasts can start to enlarge, and almost paradoxically, if you take external testosterone, your testicles can start to shrink because the testicles say, hey, there's plenty of testosterone here, we can just shut off, and you can get testicular atrophy. And testicular atrophy also results in less sperm, and you can have infertility. So that's why a lot of competitive weightlifters have problems with fertility. Now with prostate cancer, the idea that testosterone causes prostate cancer is really credited to Dr. Huggins, who actually won the Nobel Prize for making the observation that eunuchs, people who never have testosterone at all, never develop prostate cancer. So he said, oh, they never make testosterone, therefore they never get prostate cancer, therefore testosterone causes prostate cancer. And it was pretty, based on that, he won a Nobel Prize, really. And then the first line treatments, because we didn't have treatment for prostate cancer until really the 40s, no one really understood the disease. And thanks to his efforts, the first line of treatment really was castration, just removing the testicles. And then we figured out that we could use other things like estrogens, and then modern treatments such as LHRH agonists, drugs like Lupron and Eligard you may or may not have heard of. And men are a lot more partial to these types of drugs rather than getting a castration. So the mantra that we used in urology is that testosterone was fuel for the fire, for prostate cancer, and he wanted to stay away from testosterone. But what we're finding is that Huggins actually made his conclusion. His Nobel Prize, if you look at his data, and this is a really interesting presentation that was made at the American Urology Association a couple years ago. They looked at his notebooks, what he had submitted off, and they found that his entire thesis really was based on one patient. One patient won in the Nobel Prize and changed medicine, and our understanding for years. Yeah, it's kind of easy to win a prize back then.
You'll figure out one person, and then you'll get it too.
Yeah. So, really, what we're finding out now is there's really, with prostate cancers, there's really not a direct relationship with testosterone. In fact, this kind of blew us away for a while. Is that patients who had low,
so there weren't over that long period of time, there weren't follow-on
studies. No, I mean back then it was yeah.
So no one went to verify it and double check it and expand upon it.
No, because we assumed he was correct, because when men got advanced prostate cancer,
by all appearances it was correct.
Yeah, it would work. You cut off testosterone and they don't get prostate cancer, or you fight the prostate cancer. So therefore, testosterone is bad for all prostate cancer was the prevailing theory. And the other thing that was interesting is that patients who are at high risk for prostate cancer, for example, patients who maybe have been detected to have prostate cancer on their biopsies, they had just a small amount, and the doctor said, yours is the kind of cancer we can watch. Well, they had low testosterone, they had testosterone supplementation, and their cancer didn't grow out of control. In fact, in some of these patients, their cancer actually regressed on future biopsies, which is crazy. How can you give testosterone to a man who has prostate cancer? If Huggins was right, their cancer should have exploded. So again, it was just based on one patient. So now what's coming up and is popular right now is this idea of a saturation theory. This basically, imagine a glass of water. Once that, and this, let's say you're filling it up with testosterone, and once the glass, so your risk of prostate cancer doesn't increase. Well, let me say it this way. So imagine testosterone is like water for a prostate cancer. Okay, imagine it is fuel for the fire. Once you give it enough fuel, it doesn't matter if you give it more, it's not going to do anything more to the prostate cancer. So the idea is that every person can have a level of testosterone and or a level of the prostate cancer cells will respond to the testosterone, but once you give it more testosterone, it's not going to change it. So if your testosterone is low and you're having symptoms, take testosterone, it's not going to make your prostate cancer worse. So that was great in that. I was planning this analogy, and now I can't say it the way I want to. But the point is that you can give testosterone to the body without making your prostate cancer worse, unless you have really advanced prostate cancer and you have to do everything possible to slow those types of cells down. So, testosterone replacement after surgery, no longer taboo. I do it. Places all over the country now are starting to do it as well. I haven't seen anyone relapse up to this point. Now, if it does, it could be because they were going to relapse anyways. So we still check the PSA closely. We're not cavalier about it. But clearly, risks with testosterone and prostate cancer have been overstated. Here's just an interesting fact. Who here do you think has more testosterone? Really,
I think the little boy.
Yeah, you'd think the little boy, but actually their levels are the same. They're the only time you have a difference in testosterone is initially in utero, but then after puberty. Once you hit puberty, then boys' testosterone kicks up, but before puberty, their testosterone levels are the same. But why are boys more rambunctious than girls, right? I mean, it's actually in utero because their testosterone was a little higher. I think that programs their brains and they're more active. I don't know. I mean, I have a daughter. My nephews are crazy, and I was like, wait, their testosterone levels are the same, but in utero, something happens to the boy's brain. This slide here shows you all the different effects of testosterone on the body. We're going to talk about the brain, heart, sexual organs, muscles and fat, and bones. So, brain. Testosterone obviously can help with people's mood. A lot of patients maybe come in with low testosterone and they feel depressed. And if you give them testosterone, they can overcome a lot of those feelings of depression. If your testosterone goes too high, you actually can become agitated, can become aggressive. It obviously has a role in your libido, your sexual drive, and I didn't have it on this slide, but there's data suggesting it plays a role with your short-term memory, your ability to recall facts. With heart disease, they're finding that there's good effects on your cholesterol level. And in one study, they found that patients have decreased chest pain with exercise. Nothing really long-term yet, but there's potential benefits with heart disease. Clearly with muscles, we know that if you give testosterone, you can help reverse atrophy. You can help build muscles. This is where all the abuse has been in the past, with shooting your testosterone so high to really ramp up muscle production. Fat. Being on testosterone can help reduce breast fat and your truncal fat, your belly fat. With bones, women who hit menopause, their bones really start to decrease in strength as they become osteoporotic. Well, the same thing happens in men, just slower. As you grow older, your density decreases, and that's how you can develop fractures. Interestingly, you need estrogen to help your bones. It's really not the testosterone, but the testosterone turns into estrogen via fat cells. There's a direct effect on the sexual organs. Restoring testosterone has improved erections in some animal models. I will say that they've done some studies in men, and they haven't been able to replicate that giving testosterone might help you with your libido, but it won't directly improve erections. But in animal models, they found that it did. So it's still a little bit out there. How do you know if you have low testosterone? Well, these are the questions that we ask on a standard questionnaire. Do you have less libido, sex drive? Do you have low energy? Have you lost weight? Have you noticed a decreased enjoyment in life? Are you sad or grumpy? Have you lost height? Erection's not as strong. Have you noticed a recent deterioration in your ability to play sports? Are you falling asleep after dinner? And has there been a deterioration in your work performance? Really, this is Dirk Nowitzki. Put a little basketball slide in there. He's upset because they didn't even make the playoffs this year. But if you've answered yes to 1, 7, or if you answered yes to number 1 or number 7, number 1 was sex drive and number 7 was erection's not as strong. That's a strong indicator that you have low testosterone. If you answered yes to any of these other 3, that's also a strong indicator that you should probably get a blood check. Testosterone is made in 2 locations. It's made by the testicles and it's made by the adrenal glands. When we measure testosterone, there's different forms that we measure. We look at your free testosterone, and then your total testosterone is if we look at the testosterone that's bound to this thing called sex hormone binding globulin and bound to albumin, and all these added together is total testosterone. This is what really matters, is your free. Traditionally, it's been real easy, though, to measure your total. It's a lot more expensive to measure free testosterone. How did we get what's normal and what's not? Literally, what they did is they took hundreds of men and they just measured everybody's testosterone. And they said, all right, most men cluster right here. We'll call that normal. And then once you're a couple standard deviations out, then you're outside of normal. So it's not any more scientific than that. It's an observation that was done. Now, what they didn't look at is they didn't see if this guy felt like he had bad erections, if he had bad energy. So this test really doesn't look at you individually. It doesn't, your testosterone could be 500, but you might be a guy who really needs to function at a level of 600. And that's where the art comes in when patients have symptoms, but their testosterone may not technically be here. They may be a guy who normally needed testosterone up to here, and now he's lost it because he's gotten older. He's still here at normal, but he's not where he really needs to be. We get a battery of lab work. Usually, we'll get a PSA and a testosterone level. We end up checking a blood count. Depending on if we're suspicious or not, there's some other tests we can get to. Prolactin, luteinizing hormone. This is an MRI, and sometimes people can have low testosterone if they have what's called a prolactinoma. It just obliterates your pituitary, and it prevents the release of testosterone. Last few sections here, treatments. There's different things. There's creams, gels, patches, injections, and then there's other detox treatments out there. Creams, this is what you can get at local drugstores that actually compound testosterone. They make it in-house. Is that okay? Because usually the creams are the cheapest. The problem with testosterone creams is that you have to trust that these labs are making it properly and that they're making it properly every time. I'll send guys to some of the labs that seem to do a good job, but I don't know if you heard of that lab that got in trouble with the injections.
So it's a compounding lab?
Yeah, these are compounded.
Yeah.
Now, the one in Boston that got in trouble was injecting it, I think it was a steroid, or they were injecting it in the spine, and it had fungal infections. Now, you have to be careful. Pharmaceutical grade testosterone is a lot more expensive, but it's held to a much higher level of scrutiny. Now, I'll still give creams to some guys because I figure if it's at least you're just putting it on the skin. It's not like you're injecting it in the back, but it's something you have to be careful about. There's a reason why it's less expensive. Gels. There's different types of gels. It's really the most common treatment right now for low testosterone. You can apply it to your underarms, you can apply it to your thighs, to your shoulders. Different companies make different types of gels. The biggest problem with the gels is that it can cause skin irritation. One day it may absorb well, the next day it may not absorb well if you're sweaty or you didn't leave it on long enough before you took a shower. You have to be very careful in contacting other people when you put on the gel. You have to make sure absolutely that it's dry because it can transfer. You don't want that to happen. You don't want your wife to have a, honey, maybe you should take my razor. You don't want that to happen. Definitely don't want kids to get exposure to that kind of thing. And you have to use it daily. There are patches. Patches right now they used to be the main way, but we rarely give patches now. The patches cause a lot of skin irritation, and the absorption's been very variable. The nice thing with the patch is you can leave it on for a week and not have to worry about it. Injections. Injections are the cheapest form of therapy. Usually we give a testosterone injection every 2 weeks, and your testosterone is level as soon as you get that injection goes up. So people kind of feel like they can feel it. They almost get a buzz off that initial spike in their testosterone. And that feels good, but these peaks and valleys that you get with injections can sometimes worsen your blood count. Your red blood cell count can shoot up because of those spikes. And that's why we have to monitor your blood work pretty carefully if you decide or your insurance decides that this is the way we need to treat you. There's other treatments out there. There's treatments where you can put testosterone right on your gum and it absorbs through your gums. Side effect, gum irritation. There's clomiphene citrate or Clomid, which is a pill you can take that signals your body to make more testosterone. We give that sometimes to people who are trying to have kids because we don't want to shut off their sperm production. And external testosterone can decrease sperm production. And there's one thing I didn't put here on the slide, but is becoming a bigger thing, is implants. We can put little implants that melt in your body. They last 4 months. And that way you don't have to worry about creams, and you don't have to, and it's a good, steady daily dose because it's not exposed to any of the variables that are on your skin. The only issue with those is usually insurance. They may balk at that. So, anyways, lots of stuff we covered. We talked about, advanced prostate cancer, low testosterone, why having a low testosterone shouldn't necessarily be considered. Well, that's just what I have to deal with. Lots of different treatments. I want to thank everybody for coming. If you haven't had anything to eat, definitely get some food, some cookies. We have some iced tea. And then I'm going to hang out here. If you guys have individual questions, feel free to ask me. Any other questions that you want to ask me with the group?
How long can I theoretically, not theoretically, but I'm on active surveillance. So could I go 5 years?
So,
yeah, potentially.
You could potentially go your whole life. For patients on active surveillance nowadays, there's more to it than just PSA and prostate biopsy. So active surveillance is just watching the prostate cancer. Your doctor detected that you have prostate cancer, and you've made a joint decision that, you know what, this cancer, something else is going to get me before this cancer will, because not all prostate cancer grows fast. So what we do is we check your PSA, but there's also other tests out there that we use. There's one called PCA3, which is a rectal exam, and you urinate in a cup. If your PCA3 stays low, that's a good sign. We use genomic testing, which we've been using with breast cancer for a few years now. BRCA1, you may have heard of that. But what we do is actually we send your tissue from the biopsy to there's a few different labs across the country, and they'll take your DNA, they'll take the genes in that tissue, and they'll compare it to thousands of other men who've had prostate cancer and they know if those men died or those men lived, and they'll match yours up to those patients, and they'll give you an independent of what you have available to you right now, data point showing your risk. So there's more, more to it nowadays than.
But I mean, I could go on for 5 years or 10 years without any advancement in the cancer. I mean, just potentially off the wall.
You could go.
I could go 6 months, or I could go 10 years.
Yeah, that's why these new tests would be key in helping you figure out: are you that 6-month guy or are you that 10-year guy?
I see what you're saying. Yeah.
So.
All right. Thank you.
You know, I had a blood test, and they said, "Oh, your cholesterol's a little high, your testosterone's fine, but your PSA's gone doubled in 6 months." So I had a biopsy. So I've got advanced prostate cancer. So then they started me on hormone therapy. So I'm thinking, hey, that if the testosterone level, if the cancer feeds on the testosterone, too bad I had regular level of testosterone. Okay, so now he says, well, when you get through the hormone therapy, your testosterone will just naturally come back to where it ought to be.
So if you have advanced prostate cancer, then you want to, that's the one situation where you want to try to turn off the testosterone as much as possible.
I'm on 3 months of hormone therapy, and then it's either surgery or radiation.
Oh, okay. So then your cancer, okay. That's...
And they want to continue the hormone therapy during all of this for a year.
Yeah, I have to probably look at your stuff a little bit more closely then to figure out what your initial status was. Because a lot of times, with surgery and hormones haven't been found. People have not found your prognosis to be better with hormones plus surgery. It has been found to be better with hormones plus radiation. Yeah, that would be something that I just want to probably take a closer look at.
But it does get confusing when one group says testosterone's not that important, another group says, oh, it can be deadly to you if you have cancer. Another group says you need to replace your testosterone right away.
Yeah,
it does get confusing.
With advanced prostate cancer, Huggins is right. But his whole idea was that testosterone causes prostate cancer. That's what's wrong.
Doctor, I contacted a nutritionist, and just to see what their point of view was, and they told me so many things. I mean, it was a long distance phone call to California, and they told me some things that you probably need to look at is you need to only eat organic meat with no hormones and no antibiotics. You need to eat more salmon. You need to take vitamin B12. You need to have a clean system. You need a probiotic in your system.
I think there's this book called Blue Zones, and blue zones are regions of the world where people live forever. They live in. Everyone lives into their 90s. It's not unusual to meet people who are 100 years old. And what they did is they looked at their diets. What do these people in these blue zones eat? And one of the universals is that they had a low carbohydrate diet. They didn't eat a lot of bread. They didn't eat a lot of pasta. Those are the sugars, basically. And so people in the Mediterranean, they'll eat hard breads, but hard breads are hard to eat. And I figure that's probably why they don't have that much bread. And they'll have a lot of fish. They don't eat a ton of red meat. And And then there's other areas where they're pure vegetarian. But so I think there's no one right answer. But the universals that you can take away is probably we should all be eating less carbohydrates because it's so plentiful here. And if you think about it, 100 or 200 years ago, really we didn't even have, we had flatbread. We didn't really have these types of breads and pies and things donuts that we have now. Pizzas. I mean, you look at folks in Japan, some of you may have heard this from me, Japanese don't have high rates of prostate cancer until they come to the U.S. and they assimilate into a Western diet, more red meat, fatty foods, and then their rates of prostate cancer come up right to the rest of us. But I really look at it's called blue zones, but it's very interesting where you basically realize there's no one right way, but you can kind of take away what are the commonalities of all these different places where people live for so long. And one of the big ones that stood out was they don't eat a ton of red meat and they don't eat a lot of carbs. All right. Yes.
I just recently had surgery, and did they test your testosterone when you're? Is that part of
the workup? Before the surgery or anything? No.
Okay.
We haven't been. No, because again, there's no causative relationship, and then after your prostate's been removed, your testosterone levels should be the same.
It's something our internal medicine doctor kind of watches year to year, and that's one of the things he does.
The testosterone?
Levels, yeah.
I think more and more doctors are. It's never been it's something that's relatively new because in the past there really weren't that many good treatments for low testosterone. And since really 2003 is when these gels and things have picked up. So I think maybe the newer or the guys who keep up or the younger docs probably check it. Maybe some of the other guys probably don't have it on the radar.
There's observations we want to do, observing the patient, things of trends.
Right.
One other thing I saw on the slide was that Medicare would pretty much approve ProVeg and cover most of the costs. But what about other insurances? Are they
Most commercial insurances follow with Medicare. They're very strict on making sure that you are indicated for the drug. Like I have to go through a checklist and make sure you have X, Y, and Z before you can get it. So most insurances will cover, but then there's the issue of deductibles and percentages that the patient might be responsible for, and that's where these assisted programs can really be helpful for those patients. My Ghost First Ghost slide didn't show up, but I had a Ghost First slide in there.
You had jerk, but no Ghost First.
Yeah. All right. Well, again, thank you guys very much. We appreciate you coming, and we'll probably have another one of these different topics, but in the next few months, so you'll get a notice from us again. All right. All right. Thanks again. Good seeing a lot of you.